Hey everyone, Dr. Ryan Wakim here. Welcome to our first inaugural podcast named Mental State. Today we're going to talk about advanced practice providers. As you know or may not, I'm a board certified psychiatrist and key opinion leader in kind of resistant mental health care here in the Pittsburgh region and at times nationally. Actually, my guest today is one of my very first APPs. Her name is Amanda Skrinjorich. She's certified as a psychiatric physician assistant. She received her master's in public health from WVU and then went on to get her master's as a physician assistant studies from Marietta College. She is actually presently our director of medical resources as well in our medical corporation, GR&W. So if you're not opposed, we'll just kind of start digging right in.
Yeah, let's do it.
Okay. First and foremost, a lot of individuals in the audience probably don't know or understand what an APP, advanced practice provider, is. And no better person than you to let us know what that is. So.
Sure. So an advanced practice provider is kind of an umbrella term that encompasses lots of different providers. In the past, it sometimes have been termed mid-levels, but we don't really use that term anymore because it implies that they have a lower level of care, which is not really the case. What that includes would be nurse practitioners, physician assistants, and also nurse anesthetists. We actually utilize all of those here in our practice for different reasons at times. So all of these providers have graduate education after their undergraduate degree, and that can be master's level or doctorate level, just depending on which program you're a part of. They have rigorous training. They have to go through clinical rotations. Each program is a little bit different, so I'll start with the physician assistants. We are trained in general medicine or family medicine, but we do rotations in psychiatry. Then if you would specialize in that area, you do basically on-the-job training. You can get further specializations in that area of psychiatry by taking specialized boards, kind of like a psychiatrist does. And that allows you to do higher level of care things like perform therapy services. However, all physician assistants and nurse practitioners are able to prescribe medications. So it's a really rigorous program, and it's, I think, a little bit more intense than a lot of people think when they hear the word assistant, or, they think that maybe it's not quite as intense, but it does require a lot of training, and you can specialize just like you do in medicine.
So, Amanda, you mentioned like APPs and various levels of training and education, and again, there's a couple of silos of there's nurse practitioners, there's physician assistants, there's midwives, there's nurse anesthetists. Can you break down maybe a little bit better what that looks like in terms of training?
Yeah, so for all of these specialties, you have to have an undergraduate degree, but that varies by provider. So for nurse practitioners, they need to be a registered nurse prior to advancing to a master's or doctorate level degree. For physician assistants, it's a little more broad. For example, I did my undergraduate degree in exercise physiology. Then you go on to a master's or doctorate level program to obtain either like a master's degree in physician assistant studies or a master's degree to become a nurse practitioner, a midwife, or a nurse anesthetist. All of these areas have to take have to be board certified. So you have to take boards whenever you're completed your education, and then you can specialize further. So when we talk about nurse practitioners, we have family nurse practitioners that we use in our clinic, and we also have psychiatric nurse practitioners. And those are two different kinds of schooling and two different specializations. They have to go through continuing education, they have to take boards, and they have to have, I actually just asked one of our nurse practitioners, like, what do you want people to know about nurse practitioners so I don't miss anything? And she said, we have peer reviews on occasion, we have to do continuing education, we have to take boards, and we provide a great level of care. For physician assistants, the same is true. We have to take boards. In the case of being more specialized, you have to take additional psychiatric boards. And for PAs, those actually have to be recertified every 10 years. So we have to take boards all over again every 10 years and do continuing education on a regular basis. I can't actually speak to nurse anesthetists and midwives, I'm not sure, but I know that all the professions have to do continuing education for sure. It's a really important part of maintaining your certification and licensure.
So just to clarify for the general population, an APP has had a 4-year college degree, and then from there, which can be highly variable. I mean, I know psychiatrists that were history majors, right? Mm-hmm. So you don't have to be a bio major or chemistry major. So some 4-year undergraduate degree with the appropriate prerequisites to get into your program. And then either a master's or doctorate level program, which can range, I believe, anywhere from 24 to 48 months or more. There's oftentimes a fairly heavy amount of clinical time, a certain number of clinical hours. Usually it's in the thousands, 1 to 3,000. I've heard some different things based on, again, where what type of provider or APP you are. And then you take your boards that you have to pass, and then you can get licensed and start seeing patients with a collaborating physician. So there's a lot of layers there. There's a lot of education there. There's a lot of specialization there. And, to your point, there's a lot of excellent patient care occurring because they've gone through, that many levels or layers of training. I can speak candidly as a physician. 4 years of undergrad, 4 years of med school, which didn't prepare me to do anything medically, and then you do your 3 to 7 years of residency, which is equivalent to kind of the APP's master or doctorate level program with the clinical hours. So when you really compare apples to apples, at least in my opinion, I said it early on. There were many times where I would take this physician assistant over this physician, or this nurse practitioner over this physician, because not everything is just book learning, right? And so knowing when you don't know, having that good rapport, bedside manner, being able to build a relationship with someone in psychiatry is ultra important. And sometimes there are people that are really great doctors. There are people that are really great at understanding every sentence in a book. But when it comes to real life implications of clinical practice, some of those people fall apart.
I would also say that a lot of the APPs to get into programs have to have a lot of clinical experience, whereas in general, when you look at medical school, the traditional medical student is, doing that 4-year program and then going straight in. A lot of nurse practitioners and PAs don't always follow that same linear path. A lot of them have been nurses for several years and have that clinical experience and that patient care aspect. Same with physician assistants that we don't always see with a medical student. Not that there's anything wrong with being a physician for sure, but just having that extra layer of experience working with people and patients and knowing how to read those signs and symptoms outside of, I read this in this book.
Absolutely. Again, there's a lot of individuals that come through as APPs that have a lot of real life healthcare experience, and that's worth its weight in gold, because you could be really great at being a book learner, but again, when push comes to shove and there's a clinical situation going on, a physician assistant or a nurse practitioner doesn't imply a lower level of care. Again, I was the chief resident. I did a lot of training in residency with other psychiatric residents and spent a lot of time with, attendings or fully, graduated and trained psychiatrists. And we actually sometimes tend to favor physicians, assistants, or nurse practitioners in comparison to a psychiatrist, just based on some real life experience. Again, to your point, as a psychiatrist, I didn't touch people through residency, period, right? Whereas if you come out of school as a physician assistant or a family nurse practitioner, you have a lot more medical, hands-on medical experience than, again, someone coming out of psych residency. So depending on, what area, what job we're looking for and what area of the practice we're trying to fill, we actually see that as a plus in some instances. And so, again, the general public doesn't probably understand that. And that's obviously why we're here today, is to help them better understand what that looks like and why you might end up seeing a physician assistant or a nurse practitioner, or in some instances a nurse anesthetist, and not a psychiatrist.
Yeah, and I think I didn't really talk about nurse anesthetists because I don't work with them quite as commonly in my day-to-day practice, but we do have nurse anesthetists that work to administer our ketamine treatments for refractory depression. So nurse anesthetists are kind of in that same field where they have to do a postgraduate education. They typically work alongside anesthesiologists, but we do have ones that work independently within our practice to administer medications that require a little bit more monitoring than your typical go get your prescription filled kind of situation.
We do, as you know, we do ketamine infusions, which is kind of a hot topic right now for mainly for depression. They're starting to do infusions for chronic pain conditions. They're starting to do infusions for like migraine treatment. And to your point, again, as a psychiatrist, I know nothing about infusing someone or hooking up IVs. Again, I haven't touched a patient, I don't know how long. So bringing a nurse anesthetist in, who in both West Virginia and Pennsylvania here locally can actually, in the setting of ketamine infusions, because it's considered sub-anesthetic, so below a general anesthesia dose range, they can actually practice almost independently. And so again, we do rely heavily on CRNAs to provide those services for us.
Having these providers that are able to be ready to treat patients and see them at a little bit more of a rapid rate than going through residency and fellowships, although we do have those options as well. You can become more specialized. It really provides the most and best care for patients because you can be supervised by a physician. In terms of physician assistants, we have to have a supervising physician. For nurse practitioners and the other providers, it tends to vary from state to state on whether you need a practice agreement or if you can practice independently. But in any case, as a general rule, we work as part of a care team. So even if we come out with a little less training than, say, a full-blown residency, we have that extra level of information if we need it, so that there are more providers providing more care to patients. So that allows, rather than trying to find an anesthesiologist, you have a nurse anesthetist that's trained and ready to go that can help patients, on an outpatient basis. Same thing with physician assistants and nurse practitioners. We can get more people care, and it's still excellent care, which is a great thing.
Yeah, absolutely. I mean, I jokingly say, we aren't graduating more providers. We certainly aren't graduating more psychiatrists. So when you look at basic supply and demand economics, the number of individuals who are struggling, especially right now with the pandemic, struggling with mental health issues or concerns, the number of people who need help, and then being able to find a psychiatrist was difficult before COVID, is obviously becoming more difficult now. So to your point, APPs are capable of providing the same level of care, with the added benefit of having some physician oversight if you have that concern as a patient, but we're able to provide care to a much larger number of individuals, providing for the greater good. So that's the stance we've taken for years, and it's now really kind of bearing its fangs, so to speak, in this pandemic, because had we not scaled up and have that provider base, we'd be leaving a lot of patients hanging right now.
And, I see patients in the clinic sometimes who, not knowing kind of what my role is, will say, so when do I see the doctor? I kind of speak to that, what you just said, when I say, you're welcome to see Dr. Wakim. We can try and get you scheduled with him, but it's probably going to be 4 to 5 months, and he's going to tell you the same exact thing I'm telling you now because he taught me everything that I know. So again, just allowing the patients to get the same level of care, but in a more timely fashion so that they're able to get better faster. It's really important, and it's something that we're able to offer, which is great.
To speak to that a little bit more, actually, talking about the care team, the other thing I think our patients and, again, the general public probably doesn't understand is, as you mentioned, whether you're a physician assistant or a nurse practitioner, especially in our practices, you always have that collaboration with a physician, with a psychiatrist. So even though I'm personally maybe not seeing patient A, if there's ever a concern, that's a team conversation we have with the nurses, with you, with me, and we come up with care plans together sometimes. And so, it's funny, people don't understand that behind the scenes, just because they're not physically being seen by me, that I don't know their name and I don't know their chart, because oftentimes to the contrary, I've been pulled in to kind of, consult on the situation. Again, I may not have the time to be able to sit with the patient that day, but we came together as a team to come up with that plan.
Yeah, I think just yesterday I sent you a text and said, hey, can you look at this person's chart? I'm not exactly sure what to do. I need another set of eyes on it. So very often collaboration, not just with the psychiatrist, but also with other providers that, other PAs, other nurse practitioners within our practice as well. The team element of it is very important, especially in our clinic.
That speaks to the therapy as well. So a lot of our patients end up getting therapy services within our practice. And again, we have a constant flow of communication. I mean, I get so many messages every day. And that we really strive to foster that relationship. And again, unfortunately, I think it's something that the general public and our patients at times don't fully understand, that that's happening on a minute-to-minute, day-by-day basis. So, Amanda, one of the things you touched on earlier that I wanted to make sure we, reiterate is you'd mentioned kind of what an APP can do. Because again, I think a lot of patients don't understand, because they may not be a physician, they may not understand exactly what role from a treatment perspective that an APP provider can actually do.
Yeah, I think it's common that because of the terminology in our names that there's confusion. So as an example, whenever I was going to go to PA school to become a physician assistant, I had a family member ask me if I was going to be giving the physician coffee and bringing him, his paperwork.
Wait, that's what I hired you to do.
A lot of patients will say, oh, I've heard this happen to my colleagues. Oh, you're just a nurse, which, by the way, is incredibly offensive on many levels. But, really not understanding what it is that we're able to do as APPs. So we can for sure prescribe medications. There are some restrictions with higher level medications like controlled substances. As an example, in our state currently, we can only prescribe for 1 month at a time, whereas a physician can prescribe refills. And for things like stimulants, we can only do a couple of days. So that can make it a little bit more tricky if you have a patient that needs those things more often or needs, longer periods of time. But as a general rule, we can prescribe all medications for the most part. We do have a high level of autonomy, specifically in psychiatry. If you're looking at other areas of medicine, you can see where you really work side by side with the provider all the time. In our case, we all have our own patient loads. We don't see the patients with the providers, but again, we do come back if there's a if there's a concern, if there's an issue. If a case is more complex, I can always, go to you and we can talk about that case. In really severe cases where I say, I'm just not exactly sure what to do, I'll sometimes refer them to the docs if I'm having a lot of trouble. So finding, being able to handle things autonomously, but also knowing when you don't. I always say, I always know what I don't know, and really being able to address that effectively.
And one of the things that we always look for when we're looking at hiring a new APP, another provider, even other psychiatrists, is do they know when they don't know, right? Because that's when you start bordering into dangerous territory. And that's at all levels. So whether you're an APP and, you feel like this is a little over your skis and you need to pass that on to a psychiatrist or, a physician collaborator. But even in the field as a physician, there's some physicians who might say, I'm a little bit over my skis here and I really need to refer them to, a specialist. So no matter who you see or who, no matter who you are as a provider, and this is really more geared towards providers, one of the most important things you can do as a provider is know when you don't know, right? So to know when to stop, take a step back, and ask for help, whether that's within the same practice or referring to someone who specializes kind of in a certain case, for instance, OCD or some of the things that are a little more niche. I don't treat a ton of eating disorders. Didn't really train on a lot of eating disorders, so it's not uncommon for even me, if I get a complex eating disorder case, to really draw in someone who has more training, more formal education in that patient population. So it really is, at all levels. You have to know when you don't know and be able to pass that on.
Yeah, certainly not a fake it till you make it situation in medicine. That's not going to fly.
Certainly hope not.
No. Another thing that we can offer in some cases, depending on certification, is limited therapy services. So that is a big difference between APPs and psychiatrists, specifically as physicians. They are trained in therapy, whereas as a physician assistant, just straight out of school, I am not trained in therapy at all. However, when we get advanced certification, so as an example, I have a certificate of additional qualifications in psychiatry. I took psychiatric boards. I have a little bit more of an ability to provide those services. Some of the nurse practitioners are psychiatric nurse practitioners, so they are trained specifically in therapy and able to provide those services. So that can get a little murky too, because sometimes you have a provider that's able to give you that in addition to medication management, and sometimes it's not quite as much of an option. But it is something that can be offered by a lot of our providers.
Again, as training and residency, there are some individuals in residency who really went the route of additional training in certain therapy techniques and theories. But there are a lot of even psychiatrists who graduate who really aren't all that well trained in more complex therapy situations. And so a lot of what even I provide when I provide therapy is what's called supportive psychotherapy. Sure. So, and a lot of individuals don't understand that supportive psychotherapy is really to be a sounding board, right? It's to be a cheerleader for that individual, to fight the fight for that person. And that's something that a lot of people just innately are capable of doing. And, you add a little bit of education around that, especially a psych certification or, again, a board-certified psychiatrist, most of that level of a provider, psych nurse practitioner, psych physician assistant, psychiatrist, understand supportive psychotherapy and are able to do that during a visit. Again, if you're getting into more psychodynamic or some of the more theory-based therapies, even most psychiatrists aren't capable of that. So
yeah, and I would argue that we almost universally defer to a therapist and say, hey, you could really benefit from that, whether you're, an APP or a physician. For the most part, we kind of leave the therapy, the nitty-gritty of it, to the therapists and counselors.
Well, unfortunately, that's all the time we have today, Amanda. I really appreciate you driving up here and making the time to sit down face-to-face and have this conversation. Did you have anything else you wanted to touch on? Any final hurrah or goodbyes?
I think that what I would say, just as a final thought, is that, we provide the same kind of care that physicians provide, in the sense that we all want very much what's best for the patient. So whether that's with me or with you, I want whatever's best. And that's what I will always strive to do. And I think I could say that for all practitioners.
Yeah, absolutely. Again, thanks for making the time. Thanks everyone for listening to our inaugural podcast here at Mental State. Don't forget to subscribe so that we can bring you some more very psychiatrically driven content. Have a good rest of your day.